going to present a case of bilateral angle closure glaucoma in acute posterior multifocal placoid pigment epitheliopathy. It's not moving. Yeah. This is a case of 25-year-old female presented with the blurring of vision in both the eyes, right eye more than left eye. BCVA, intraocular pressure, anterior segment, posterior segment, and OCT was done. All were in the normal limit. She was asked for a follow-up after 1 week, but then she came again after 3 days with complaint of blurring of vision, both eyes, right eye more than left eye. It was sudden, progressive, associated with moderate to severe headache. No history of any systemic disease. On examination, BCVA, right eye CF 2 meter, left eye 6/12. IOP was normal. Pupillar reaction, right eye sluggish, left eye normal. Color vision, right eye 1/25 plates and left eye normal. Slit lamp examination within normal limit, both eyes, no uveitis. And dilated fundus examination, media clear, no vitreous cells in both eyes, but multiple grey white placoid, blister-like lesion in both the eyes in the posterior pole, right eye more than left eye. This is the fundus picture. You can see multiple placoid lesion, right eye more than left eye, and the right side is the autofluorescence picture. Then OCT was done, shows right eye a huge bacillary layer detachment which is known as Ballard, and left eye the serous detachment of retina is there. And this is the picture of FFA and ICG. Left side denotes the right eye and this is the left eye. All your phase there is total choroidal plus, and in between phase, every phase you can see the hypo, typical of APM-PP, and late stage hyperfluorescence of the FFA. But ICG every stage it is hypofluorescent. But in the left eye there is one phase in ICG you can see there is hyperfluorescence. So this is a dilemma whether it is APM-PP or VKs. Because APM-PP, VKs both relatively same presentation. There is a subtle difference between the two, but during the course of presentation we thought APM-PP because of response to treatment and all. I'll tell later. So all investigation, blood, MRI and brain orbit CT chest to the normal limit. She was diagnosed as a case of APM-PP, can be VKs, and started with high dose methylprednisolone and asked followed by oral prednisolone and asked for follow-up after 7 days. But surprisingly, patient came again after 4 days with complaint of left-sided headache, but vision was improved. BCVA, right eye 6/18, left eye 6/6 partial, IOP 13 right eye, left eye 22. There was shallow AC in both eyes, gonio done, 360-degree angle closed in both eyes. So immediate YAC-PI was done in both eyes, steroids were continued, and advised for a follow-up after 7 days. Patient was doing well after that. This is the picture YAC-PI done in both eyes. And after 15 days presentation, you can see the central macular thickness fluid grossly reduced, and after 1 month follow-up, 1.5 and 4 month follow-up. Right now also, after 1 year, patient is presenting like this, quite okay. This is the picture of ultrasound D scan at the choroiditis she also had at the time of presentation after 4 months. It is, choroid appears to be normal, no choroidal thickness. So my take-home message is APM-PP or VKS. Glaucoma is very rare complication and rare manifestation. Acute angle closure glaucoma is not a common manifestation, but pathogenesis can be due to acute inflammatory edema or inflammatory cells being close to the trabecular meshwork or damage to the blood aqueous barrier causing ciliary body rotation, then forward movement of iris and lens causing pupillary block. So differential can be this, and this is the reference. Thank you.
So what was the cause of glaucoma? Was both the eyes shallow antechamber before the?
No. Before it was absolutely normal.
Normal.
Because absolutely AC was reached.
So
normal.
what pathogenesis you were seeing?
That's what inflammation and pushing of the lens side because of the ciliary body swelling and deposit of trabecular. They say trabecular meshwork inflammation, ciliary body swelling, pushing of the lens iris diaphragm forward causing pupillary block.
And treatment-wise, what is difference between AMPP and VKH?
Treatment virtually same, but only thing difference why it is more in favor of APM-PP than VKs. Typical VKs will get starry eye pattern, more sort of hypo and hyperfluorescence, pinpoint, and proximal, and in the long not associated with any cutaneous symptoms like vitiligo, poliosis, which is happening in case of vitiligo, not in APM-PP, and fundus picture and chronicity. VKs won't usually they respond to steroid. But again, recurrence is there. But we are following up for 1 year. There is no recurrence. But patient is still on 5 mg Visolone. We are continuing thinking, she is a young girl, 25. So thinking by chance it will, and she is tolerating well. But Absolutely stable now.
Only thing I wonder with that thing is that how did the pupillary block happen, because the patient was already on steroid for very long.
So that is what's surprising.
Yeah,
that is the main
that is the
presentation.
surprising.
My question is, it was already bilateral shallow anterior chamber with repeated dilatation.
No. We are following her up.
Uh,
We are following her up.
Okay.